Hi, today I would like to share with you about Alport syndrome and Goodpasture syndrome. If you are not familiar with these two, you may wonder why I put them together. But after you listen to this video, this help you memorize and linking them together, then you don't have to go through them again. Like usual, I like to start with a case. We have a 10 years old boy present with gradual onset of short sight, and his mom claimed there's no pure medical history and with normal development, although sometimes her son cannot respond to her at once. So this is a point. And then we have examinations. We have examination find that's reduced visual acuity and lens protrusions, and we have a blood pressure with 152 with 94 millimeters mercury, and this is pretty unusual in such a young kid. And then so when you see this, you order a urinalysis, and here we have the results already, and I've marked them out too, so you can see there's a high potassium, high urea, and high creatinine. So you probably come up with a small conclusion of there's probably something wrong with the kidney, and then you combine with other things you find from this case. That's what I circle here. So why does this boy cannot respond to his mom at once? So you think of maybe there's something wrong with his hearing. So now we have the clues together. There's something wrong with hearing, and then we have kidney problem, and we have eye problem too. This is Alport syndrome. So what is it? This is a X-linked dominant disease syndrome. So that's why we have a case of a boy, because male are more high risk in this case, although you can also find it in some girls. But like X-linked dominant, you think of a boy. And then this is a genetic defective of type 4 collagen. If you know Goodpasture, you see this, you know why I put this in this topic too. But if you don't understand, you can keep listening. And then this type 4 collagen is the component of basement membrane of kidney and also eye and cochlea. And that's why the damage to these structures causing these three disease or symptoms. We have glomerulonephritis, which you can see a gross hematuria, and then you find some nephrotic syndrome and even develop a chronic kidney disease. Then you have a sensory new hearing loss. Usually this is a bilateral thing. And then you also have ocular abnormalities. So here we have an anterior lenticularis. In here, this is variolis. I have a picture here. So this is the one. And then this syndrome, you may have to order urinalysis, which we have done it already in the case. And then BUN is some usual stuff for the kidney disease. And that's specifically for Alport syndrome. You order a skin biopsy, then you will find an absence of collagen type 4 alpha 5 chain, absent of this. And then you can also order the kidney biopsy. And then you order a molecular genetic test and other tests like audiometry and then ophthalmic evaluations. And I have prepared the kidney biopsy sample in the next slide here compared to normal kidney. So in Alport syndrome, this is an electric microscope. You see a basket with appearance, which is basket like this, my poor drawing. If you don't know what it is, please Google it. And then compare to the normal kidney biopsy, you can see here. The glomerular basement membrane is here, the gray part here, and you can compare it obviously here. There's a thickening and thinning of the membrane structures, and there's alterations and they are irregular, and this is the structure you have to recognize. Even though you know this is Alport syndrome and this must be a sensorineural hearing loss, but in real life you may not know, and this is a confusing situation. So this time we have to perform the Rinne and Weber test. So you firstly perform the Rinne test. You pick a tuning fork, and then you first you put it horizontally and put the tip on the mastoid bone, and this is a bone conduction, and you ask the patient to hear it and memorize how the sounds volume till he cannot hear the sound completely. Then you transfer into this position, and this is air conduction, and ask the patient to hear the sound generated by the tuning fork. And then here is the most important part. You ask whether the patient, the first bone conduction is louder or the second air conduction is louder. If there's the second one, air conduction is louder than the bone conduction, then that's normal for this patient. But if the bone conduction, which is the first step, is louder than the second step, air conduction, then you can interpret it as a conductive loss. Why and what is the theory behind it? We have two hypotheses behind it. So a conductive loss means there's something wrong, let's say in the middle ear, right? Maybe there's something external ear, but let's take middle ear as an example. Maybe there's a membrane rupture, or maybe there's a otitis media. And anyway, here it's not functioning, let's say it's damaged, and then so here this part of the inner ear, the cochlear, it up-regulate the sensitivities, so the sounds louder through bone conduction. And the second hypothesis is the sound, because they cannot transmit through the bone, the small bones, normally. So the sound kind of like trap here, and then they accumulate. So you have a larger, let's imagine it's like a volume here, and then that's why the patient perceives larger volume. So he hear larger sound through the bone conduction. And this is the two hypotheses. And okay, so we now have the result from the Rinne test. Then you have to run the Weber test. These two must combine together to interpret which part and which type of hearing loss it is. So with the Weber test here, let's say there's something wrong with the right ear from the previous Rinne test. So the bone conduction is larger than the air conduction in this patient. Then you perform the Weber test, which you put the tuning fork immediately on top of the scalp, and then normally the sound should transmit equally, and then on both sides, and then hear the same volume. But there might be falsely interpreted as the patient as normal, such as in this case, the Alport syndrome, because usually in such syndrome, this is a bilateral hearing loss. So you might falsely diagnose this as healthy, but just put it in mind. And then, but still you have to understand what happened this time. So back to our topic. Sorry, a bit off from that. So let's say the patient, you suspect there's a right ear conductive loss. So this mechanism of this test is through a bone conduction, right? So as I mentioned and explained before, if there's a conductive loss, the bone conduction is larger on the affected side. So affected side here. So the patient will give you a result that he can hear a larger voice on the right side, but lower volume. psalmodium on the left side. So combined with this result, you can give a diagnosis of there's a right side, right ear conductive hearing loss. But if there's a sensorineural loss, such as like in this case, in Alport syndrome, although it's not one side, but so anyway, so the inner ear, there's something wrong in the inner ear. So the bone conduction is not gonna work, right? So this side, the patient may not hear from this side. And the other side, the inner ear, is normal. And this is a sensorineural loss. Still, you have to combine with this test to give a conclusion. And then, because I mentioned that these two tests may not help you to give a falsely diagnosis, so usually you have to do an audiogram, which also called a pure tone test. So I might look quite difficult, but actually it is it's quite easy. So this is a threshold here, and then you know that Alport syndrome, that is a sensorineural hearing loss. So in the case of such hearing loss, both of the bone conduction and the air conduction, they both increase the threshold proportionally. So you can see from this graph, they increase together. And then this is both the right ear and left ear. So you can give a conclusion of this is a bilateral sensorineural hearing loss. And I also prepared an example of a conductive hearing loss for you to differentiate. So this is right ear unilateral conductive loss. Why? Because in this conductive hearing loss case, only the air conduction increase the threshold, but the bone conduction is fine. And then in this case, the right ear is fine. And then we can give a conclusion of there's a right ear conductive hearing loss. Anyway, so what is the treatment of this Alport syndrome? Unfortunately, the only definite treatment is a kidney transplant. But before, unfortunately, there's not much we don't have the luxury to give every patient this plan, so we have to stick on a symptomatic treatment. We have to try to relieve the proteinuria by giving ACE inhibitor, angiotensin 2 receptor inhibitors, or sodium glucose transport 2 inhibitors. And so the patient also will develop renal failure, so you just have to treat them according to how you treat the chronic kidney disease, such as by sodium restriction or give them diuretics. And then, back to the topic or the title of my video, why I put Alport syndrome and Goodpasture syndrome. And this is why here, a kidney transplantation. Why? Because after you cannot think that after the patient successfully get a new kidney and everything is fine. No, you have to be prepared of one day you see the patient back to you and they say, oh my god, doctor, I'm coughing with blood, I feel so I can't breathe, it's so hard, I feel everything is like unusual, and my kidney, I still have blood in my urine, what happened to me? The patients probably have a Goodpasture syndrome. A Goodpasture syndrome, what is this? This is a syndrome of you have auto antibodies attack the type 4 collagen. In this case, because the previously the patient doesn't have type 4 collagen. That's why they have all these things like hearing loss, the eye anterior lenticularness, and then have the kidney failure. But then when the body encounter a new type 4 collagen, they recognize it as an enemy and start to attack it. So they have a type 2 hypersensitivity. And then I mean, this is very, very unfortunate situation. So the patient will have hemoptysis, dyspnea, coughing, and start to show the symptoms of RPGN. I mean, the rapidly progressive glomerulonephritis. And then, yeah, that's how you memorize like the Goodpasture Syndrome with Alport syndrome, and now you can learn them like together. And as usual, the definite diagnostic test for kidney disease is the renal biopsy. So you have the immunofluorescence microscope or the electron microscope. So in a immunofluorescence microscope, you will find a linear deposition of IgG, a non-alveolar and basement membrane. So as usual, I prepare an image for you to better understand. See, you can try for to identify which one is the normal kidney and which one is the one being affected. Anyway, I hope you can find it out, but not by looking at the link I put below the pictures. Okay, this one is a normal kidney, and this one is the kidney with a Goodpasture syndrome. With the normal kidney, you can see this one. You can compare. Obviously, there's like dark green, or green outline compared to the normal kidney, right? And these are the linear deposition of the IgG, and this is how you understand how to read the microscope. And then, yeah, I mean, and then by the electron microscope, you see the bricks of glomerular basement membrane. Unfortunately, I cannot find a better image for that, but still, this is an easy one. So if you are interested, you can Google the image. Anyway, also you have to order some lab tests. You will find anti-glomerular basement membrane antibodies against the type 4 collagen one. And then you'll find there's a hemostatin filled macrophage in sputum, because these antibodies are also attacking the type 4 collagen composed like in their real life. And then since it's attacking the membrane, and then you have a blood loss, of course there will be an iron deficiency anemia. And this is, and the treatment for this Goodpasture syndrome is high dose glucocorticoid with cyclophosphamide. And then some may ask which glucocorticoid to use. I already prepared for you here. It's a mifepristone. And then if there's a serious case, and you might have to prepare for the patient for the plasmapheresis. And this is my reference. And thank you so much for listening to my video, and I hope it helps. And thank you.